Good afternoon, dear team members and Dr. Rajini. Today, my topic presenting on care of patient with septic shock secondary to pyelonephritis. Okay, my learning objective for today is describe what septic shock and pyelonephritis, explain the pathophysiology of septic shock in the context of pyelonephritis, what is clinical manifestation of septic shock and pyelonephritis, and complication of septic shock in pyelonephritis, case analysis presentation, discussion on health education. Okay, what we know about septic shock and pyelonephritis. Actually, what is septic shock? Septic shock is a serious health issues that can arise when an infection causes extremely low blood pressure and organ failure as a result of sepsis. What is pyelonephritis? Pyelonephritis is a bacterial infection that causes inflammation of the kidney. Pathophysiology of septic shock in pyelonephritis. The onset of septic shock due to pyelonephritis is marked by a significant kidney infection that releases bacteria into the bloodstream, causing a symptomatic inflammatory reaction, which is the bacteria is going through the kidney and then later enter to the bloodstream. This is cause a systemic inflammatory reaction. This reaction promotes the immune cells within the body to secrete inflammatory mediators, causing vasodilation and heightened vascular permeability. As a result, there is a significant reduction in blood pressure and a decrease in blood flow to the organs. Okay, clinical manifestations, which is pyelonephritis turn to septic shock. First, we go through the pyelonephritis signs and symptoms, which is flank pain, fever, hematuria, dysuria, shaking or chills, or nauseated or vomiting. These are the symptoms of pyelonephritis. We go into the septic shock signs and symptoms, which is hypotension, which is low of blood pressure, drowsiness, cold or pale, little urine output, and tachycardia as well. Complication: acute kidney injury, which is AKI, leading to decreased urine output and increase in waste products like blood, urea, nitrogen, and creatinine. Multiple organ failure, which is from kidney failure to other organs as well, which is heart, lungs, all will day by day will become deteriorating. Renal abscess, an abscess can form within the kidney, often due to a blockage or ascending infection. Respiratory failure, the lungs may not be able to take in enough oxygen due to inflammation and injury to the pulmonary capillaries. Okay, we go into the patient's biography data. Okay, Miss S, age factor is 66 years old, female, date of birth of 25th of June 1972. Patient non-case of hypertension, diabetic, dyslipidemia, ischemic heart disease, and previous history of cholelithiasis as well. Patient diagnosis was septic shock secondary to pyelonephritis. No allergic to any medications or food. What was admitted in ICU and General Ward 1. Date of admission was 1st of October 2025 to date of discharge 10th of October 2025. Admitting doctor was 2 doctors, which is physician and nephrologist. Case scenario: I could receive a call from the patient's son regarding his mother who has been experiencing fever and lethargy, making her unable to walk since this morning. I confirmed the details with the son about the patient's age, comorbids, body weight, and a responsiveness as well. She reported a sudden onset of left flank pain, nausea, fever, and dizziness lasting for 1 day. Vital sign was taken in ambulance. Was BP was reading 156/72, normal, a bit high. Respiration rate was 19 per minute. SpO2 was 98% under room F. Heart rate was 79 beat per minute. The glucose level was 88.5, temperature was 38.8 degrees Celsius, which is fever, GCS of 15/15. Upon arrived to emergency department, the BP was decreased lah to 89/50. Respiration rate was 19, SpO2 was 98% under room air, heart rate was 86, temperature was 38.4 degrees Celsius lah. What are the investigations we were done in emergency department? Which is food blood count, liver function test, renal profile, lipid profile, thyroid function test, CRP as well. We can go through from the white full blood count. The white cell was 15.6. The liver enzyme also bit elevated lah. The bilirubin was 25, bilirubin direct was 8.3, bilirubin indirect was 16.7. And then the CRP level was quite high, 139.6. VBG lactate also we done. The lactate level was 2.43. The pH level is 7.32, which is a bit acidotic as well, the patient. Renal profile, the creatinine level is 148, elevated. CT abdomen, the features could be due to left pyelonephritis lah, compound pyelonephritis. Chest X-ray was normal lah. ECG was normal sinus rhythm. Management and treatment was given in emergency department. We inserted large bore of IV line lah with this 18 gauge. We inserted 2 line as well lah. And then we started with fluid resuscitations, IV drip normal saline 0.9%, and then run with Hartmann 1 pint bolus. And then we start antibiotic IV in once 1 gram, IV Nexium 40 mg, IV Ondraset 4 mg, and then IV PCM 1 gram as well. Catheterization bladder drainage, CBD was inserted for this patient. 14 catheter for monitoring intake and output of the urine, and then patient referred to nephrologist as well for AKI management. Nursing care plan, nursing diagnosis. First nursing diagnosis is risk for infection related to bacterial pyelonephritis as evidenced by high white blood cell count lah, which is just now the white blood cell was 15.6 lah. Okay, goal is prevent worsening of infection and further complication lah. So nursing intervention, administer prescribed antibiotic as ordered by consultant, which is IV in once 1 gram OD and IV meropenem 1 gram BD given as per correct time and route lah. Monitor white blood cell and CRP count daily to help to determine whether patient's infection response to the antibiotic given either increase or decrease of the infection. Maintain strict hand hygiene to prevent new infection towards patient. 5 movements and hygiene method use lah. Okay, monitor patient's vital signs, focus on temperature. Patient temperature monitor in emergency department in ICU hourly to detect signs of worsening infection. Assist patient with daily bathing and change daily linen and gown of the patient. To prevent from further infection, daily morning bed bathing patient, checking for any early signs of bed sore and rashes development. So final evaluation for the nursing diagnosis is patient's condition improved slightly, temperature remain in febrile 37.5 to 37.7 degrees Celsius, white blood cell and CRP count increase not indicated a positive outcome. In view of patient current condition, needed infection disease treating consultant. Skin remain intact with no new rashes or bed sore noted. Infection control measures such as hand hygiene and environmental cleanliness were effectively maintained. Patient alert and comfortable. Okay, we're moving to second nursing diagnosis, which is hypothermia related to disease process as evidenced by body temperature 38 degrees Celsius. Goal is to reduce body temperature to normal range and promote comfort. Nursing intervention was First, monitor temperature every hourly in A&E and ICU in ward for 4 hourly. It will determine early stages of worsening infection, response level of treatment. Second nursing intervention is to promote cold service as a tepid sponging or overflow of patient. Rationale to reduce temperature through evaporation and conduction, application of wet dressing, pad of patient forehead. Third, administer antipyretics as ordered. Reduce fever and discomfort, administration of paracetamol 1 gram PRN. Monitor intake and output patient on urinary catheter to monitor hourly intake and output patient in A&E and ICU. Early detection sign to prevent multiple organ failure. Evaluation, temperature has returned to within normal range within the planned time frame. The patient remains afebrile or fever is significantly reduced and stable. Third nursing diagnosis, risks for imbalanced fluid volume related to excessive fluid loss and renal dysfunction. Goal is to maintain adequate fluid balance. Nursing intervention, first monitor intake and output closely. Rationale, patient on urinary catheter to monitor hourly intake and output patient in A&E and ICU. Early detection sign to prevent multiple organ failure. Assess for signs of dehydration or fluid overload. Detects complication and of inappropriate fluid management. Signs such as intake of 500 ml of Atman given but output 100 ml. Administer prescribed IV fluids and electrolytes. Rationale to restore volume and prevent shock progression. Started on Atman 3.0 for 24 hours regime. Evaluation, patient's fluid balance improved with intake and output within acceptable range. Vital signs stable with normalization. Blood pressure and heart rate. Unit output adequate with clearly appearance and normal frequency. Progression of patient status in emergency. To up sepsis bundle to commands within 1 hour, which is compulsory. We need to up the sepsis bundle within 1 hour. And then final diagnosis of this patient is gram-negative urosepsis with septic shock and AKI. In ICU second day of admission, this patient started on IVI noradrenaline with single strength in view of low blood pressure. Started on nasoprong 3 liter in view of SpO2 93% under room air. VBG lactate noted with metabolic acidosis. Blood investigation was repeated again in the ICU, which is blood cell increased again 16.4. The CRP level was extremely increased, which is 406.5. Started on IV meropenem 1 gram. In ward, still fever persistent. In febrile temperature 37.5 to 37.7 degrees Celsius. The white blood cell in the ward 19.9 and CRP was reduced a bit 161.1. This patient was transferred out to PHKL on 10th of October 2025. Case referred to Dr. Anusha, which is infectious disease specialist, through ambulance accompanied by ward staff. Latest update from PHKL, which is Pantai Hospital, Kuala Lumpur, 24th October 2025, repeated CT abdomen 4 phase with contrast. The finding was left pyelonephritis with intraparenchymal abscess and 2 subcapsular collections, which is the complication of the pyelonephritis. So mostly health education, what are the health education normally can give for this kind of patient is recognizing early warning signs. Teach patients to monitor for fever or chills, rapid heart rate or breathing, confusion or dizziness, decrease in urine output, low blood pressure symptoms like body weakness, like fainting. Infection prevention strategies, practice good hygiene, avoid exposure to sick individuals and crowded places during recovery, maintain clean surroundings and proper food handling, hydration and nutrition, encourage adequate fluid intake to support kidney function and circulation, promote a balanced diet rich in protein, vitamins and minerals. Okay, thank you so much. That's all from my presentation for today. Okay, my questions for today is, if this kind of patient with sepsis, which zone category guys will triage normally? So I encourage these patients to be triaged in at least yellow zone lah, because it's a sepsis patient, septic shock somewhere. So triage in yellow zone. My second question is, already the doctor's diagnosis is to septic shock due to pyelonephritis. So within how many hours to up the septic bundle? So our hospital, our department KPI is sepsis bundle to commats within 1 hour lah, for all patients compulsory, which is for sepsis, urosepsis or anything, have to up within 1 hour. Okay, that's all. Thank you so much.